My name is James Hill. I'm Clinical Professor of Surgery at Manchester Royal Infirmary in Manchester, UK. I'm presenting on the CREST trial, which is a randomised phase 3 study of stenting as a bridge to surgery in obstructing colorectal cancer. Colorectal cancer presents as an emergency still in around 20% of patients, and 1 in 6 patients will have their surgery done in the urgent or emergency setting. Morbidity and mortality remain significantly higher in the emergency patients compared to the elective setting. There's a rationale for converting an emergency into an elective surgery, which would include better preoperative preparation of the patient, improved staging, and referral to a specialist colorectal surgeon. Currently, stenting as a bridge to elective surgery is not recommended in the European guidelines, largely because of concerns about the efficacy of stenting, but also concerns about an increased risk of disseminated malignancy. Primary objectives to CREST were to assess perioperative morbidity by looking at length of hospital stay and to look at 30-day postoperative or post-procedure mortality. Secondary outcomes were stenting, stoma rates, survival at 6 months, and proportion disease-free at 3 years, and also quality of life and perioperative morbidity. Simple trial design, randomizing patients to emergency surgery or insertion of a stent, and those that had successful decompression went on to elective surgery 1 to 4 weeks later. Patients with progressive or advanced disease could go on to palliative care only, and if stenting failed, they had emergency surgery. We attempted to randomize 400 patients. The eligibility criteria were those with a left-sided obstruction believed to be secondary to colorectal cancer, with no evidence of actual or imminent perforation. Looking at compliance with treatment, randomized treatment allocation, this was very good. There were 123 patients in the stent arm and 122 in the emergency surgery arm. And in both groups, well over 90% of the patients were considered to have potentially curative disease. Patient demographics show that the groups are well matched for gender, mean age group, median Apache score, and also well matched for site of tumour and ASA grade. At the primary endpoints, stenting did not reduce the length of stay nor the 30-day mortality. There's a Kaplan-Meier curve on the left and on the right, a table showing that the median length of stay was 14.5 days in the stenting arm and 13.5 days in the surgery arm. Death rates were low in both groups. There were 4% with stents and 5% with emergency surgery. Stenting was successful in relieving the obstruction in 82% of cases, which compares well with other published studies. The vast majority of procedures were performed as endoscopic and fluoroscopic technique. There were 6 stent-related perforations in the study. 5 resulted in urgent surgery. 1 patient required stenting only. There were no postoperative deaths, but 1 patient did require mechanical ventilation. Importantly, stenting does appear to reduce stoma rates. The results are shown on the slide, and the difference between the 2 groups was highly significant. 6-month survival rates were not different in the 2 groups, in particular looking at those cancer patients only treated as a bridge to surgery. There was no significant difference in cancer-related mortality at 6 months. Surgical complications also didn't differ between the 2 treatment arms. So in summary, we were pleased to note that 70% of patients who were approached were willing to be randomized into the study, and there is a less than 10% false positivity rate. Combined endoscopic and fluoroscopic techniques result in good technical and clinical relief of obstruction. Mortality and length of stay were unaffected by stenting as a bridge to surgery. However, stoma rates were significantly reduced, and importantly, cancer-specific survival was not worse. And therefore, we believe that stenting as a bridge to surgery is a reasonable alternative to emergency surgery. Thank you.